Children are not just little adults. Their physiology, psychology, and cognitive abilities, as well as social understanding, are all different. So, it should be no surprise that the clinical encounters with children take place in a different moral space than it does with adults. This video explores the ethical norms that guide pediatric care and decision-making. Consider two scenarios. A 27-year-old man is critically injured with a traumatic brain injury, and he lies in an ICU unable to decide for himself. At the same time, a 27-month-old child who is also critically ill lies in an ICU after a hypoxic brain injury. In both cases, the medical team goes looking for a decision maker and turns to the patient's mother at the bedside for guidance. Though some of the medical and institutional features in both cases look similar, the question is, are the ethics of the decision-making the same? For adults, medical ethics begins with respect for patients' own values and interests. If the patient cannot speak for themselves, a substitute decision-maker is identified, often a family member, who is asked to make decisions based on what the patient themselves would have wanted. This approach attempts to honor the patient's own prior autonomy and interests. In pediatrics, however, moral expectations shift. We begin with the presumption that children lack the capacity to make complex medical decisions. Parents are therefore given authority to decide based on what they believe is in their child's best interest. This creates a fundamentally triadic relationship among patient, parent, and provider, one that requires its own ethical norms. Two key principles guide pediatric ethics. Parents are expected to act in their child's best interests, while providers are guided by medical beneficence, or offering medical options that have the possibility of physiologic benefit. But conflicts arise when parents and providers disagree. Parents may not fully understand medical risks, while providers may not see the whole picture of the child's life. While parents may aspire to what is best for their child, society cannot demand that parents always meet such high aspirations. In fact, all that is demanded of parents is that they do good enough. This then allows for a wide scope of parental authority. That is, if the decision is concerning but not harmful, the provider's role is to persuade with care and professionalism. But that does not mean the authority is limitless. The moral limit is reached when parental decisions violate what's called the harm principle in pediatrics, when choices place the child at imminent risk of serious harm that could otherwise be prevented. In such cases, providers must involve state authorities. Of course, most parents are very well-intentioned, going to great lengths to protect and support their children. However, sometimes this may lead them to demand more than medicine can reasonably provide. In such cases, providers determine the limits of reasonable medical options, balancing compassion with honesty, ensuring that care remains appropriate. Good communication and established processes for resolving conflict are essential. And while minor children are subject to parental authority, most children grow and develop over time, physically, socially, and cognitively. As they mature, their developing autonomy should be considered by including them in discussions about their care, at least to the extent that they are capable. Some, though not all, ethicists argue that mature minors, those who demonstrate understanding and judgment, should be allowed to make certain medical decisions for themselves. However, there may be some legal constraints on this, and so whether a minor's own consent can be recognized depends greatly on state law. Given the unique moral space of pediatrics, ethicists have outlined a set of 6 normative recommendations that guide practice. These norms help define the responsibilities of parents, providers, and patients in pediatric care. First, parents should be presumed to have wide, but not unlimited, discretion to make healthcare decisions for their children. Second, parents should protect and promote the health interests of their child, while balancing practical constraints and/or other important obligations and interests. Third, a clinician's responsibility is to protect and promote the pediatric patient's health interests. Clinicians' recommendations should be informed by professional judgment and the best available evidence. Fourth, to respect children and promote their well-being. Clinicians and parents should inform pediatric patients of salient information and invite their perspectives to the degree that doing so is developmentally appropriate. Fifth, in addition to state-mandated reporting requirements, clinicians should seek state intervention when all less restrictive alternatives have been exhausted and a parental decision places the child at significant risk of serious imminent harm or fails to meet the child's basic interests. Sixth, clinicians and parents should collaborate in a shared decision-making process to promote the child's interests. These 6 recommendations provide a framework for navigating the complex moral space of pediatrics. By balancing parental authority, medical expertise, and the child's developing voice, we can ensure that care is compassionate, ethical, and just.